Hello everyone. Today we are going to see two cases of diffuse midline gliomas. The case 1 is a 19-year-old female who presented with left upper limb weakness since a month. The MRI revealed altered signal changes involving upper cervical cord from mid portion of C2 through upper border of C5 level. The cord displayed T2 hyperintensity and T1 hypointensity signals in this region, with significant expansion of the left hemichord in this region with slight nodular appearance. The lesion measured 38 into 9 into 11 mm. Post-contrast images showed moderate and heterogeneous enhancement involving this enlarged part of the left hemichord. And case 2 is of a 24-year-old man who presented with seizures since 1 month. His MRI revealed an ill-defined T2 flare hyperintense signal intensities over the right CP angle involving right anterior cerebellar lobes, right lateral aspect of the pons, right cerebral peduncle, and extending over small focal area of right thalamus and left anterior cerebellar lobes surrounding the fourth ventricle and the vermis, showing few areas of flare hypointensities and subtle restrictions on D1 weighted sequences. We received the two tumors in our lab. So one tumor was from Kolhapur and other tumor was from Solapur. Now this is histopathology of case 1. So it was a diffusely infiltrating astrocytic tumor with moderate cellularity. Some foci showed increased cellularity, nuclear pleomorphism was noted, and occasionally nuclear multinucleation was noted, and occasional mitotic activity was seen. However, microvascular proliferation and necrosis was also evident. Rosenthal fibers and eosinophilic granular bodies were absent. The histology of the second case showed cerebellar tissue with pyloid gliosis in one slide, and the other slide revealed a diffusely infiltrating astrocytic tumor with increased cellularity. The cells had neoplastic cells had high NC nucleocytoplasmic ratio, hyperchromatic nuclei, and moderate amount of eosinophilic cytoplasm. Binucleation, multinucleation, and mitotic activity was evident. Background was fibrillary. Microvascular proliferation and necrosis was absent. Immunohistochemistry of case 1 showed GFAP and OLIC2 positivity. Now this tumor, we did H3K27 triple methylation and loss of nuclear expression was observed. So we later on proceeded with H3K27 which showed mutation. The tumor was EMA, P16 and SOX10 negative, and the MIB1 was high, 10 to 12%. In the case 2, similar findings were seen, that is, it showed triple methylation, loss of nuclear expression was noted, and H3K27 mutation was seen. And we also did the other markers to rule out medulloblastomas such as synaptophysin. We did chromogranin, CK, LCA to rule out lymphomas, GAP1, YAP1, OTX2.1 and beta-catenin were negative in the cells, and the Ki67 proliferation index was high, 15%. Now it is important to note that the tumors showing histone mutations are negative for IDH. So IDH1 we found negative, and H3K27 triple ME3, that is triple methylation tumors, show loss of H3K27 ME3 in the tumor cells. This may be helpful in identifying diffuse midline gliomas with H3K27 mutation or those with easy hip overexpression, which are negative for H3K27M but show loss of nuclear expression for H3K27 trimethylation. The diagnostic criteria for diffuse midline gliomas H3K27 altered are: the essential criteria is it should be a diffuse glioma and there should be loss of H3K27Me3 on immunohistochemistry, and the location should be midline, and presence of H3K2728 mutation should be seen, or the mutation of other subtypes must be observed, or presence of pathogenic mutation or amplification of EGFR for EGFR mutant subtypes, or overexpression of EZ-HIP should be seen when the tumor is histone wild type with EZ-HIP overexpression, or we can do methylation profile for one of the subtypes should come positive. So we gave the impression of diffuse midline glioma, H3K27 altered, CNS WHO grade 4, and these tumors showed H3K27 mutation, which was done on immunohistochemistry. So the pediatric type diffuse high-grade gliomas are separate entities described by the new WHO, that is the CNS WHO 5. The adult type diffuse gliomas and the pediatric type diffuse gliomas have been completely separated. However, there might be overlapping in both the age groups. Now, the pediatric type high-grade diffuse gliomas could be either midline or hemispheric. The midline tumors are H3K27 altered, and the subtypes are, they could be H3K27 mutant, diffuse midline glioma showing EGFR mutations, and diffuse midline glioma which is histone wild type with EZ-HIP overexpression. Now coming to hemispheric gliomas, those which are found in adolescents and young adults, these may show H3G34 mutations. Those found in children are typically H3 wild type, and the infantile type of hemispheric gliomas which are H3 wild type. Now these respond well to the targeted therapy, and the commonly found mutation in the fusions in these tumors are ROS, MET1 and ALK, and also they show derangements in the tyrosine receptor kinase pathways. Coming to diffuse midline glioma CNS WHO grade 4, the pediatric type are commonly located in the brainstem, pons, and the ones in the pons are typically known as diffuse intrinsic pontine gliomas. Now, when they are found in thalamus, they are mostly bithalamic involvement. The DMGs found in adults or adolescents are usually unilateral, and they may arise in thalamus or in the spinal cord. Coming to clinical history, these tumors usually have a very short duration of less than 2 months, and the patients present with the clinical triad such as cranial nerve palsies, long tract signs such as pyramidal tract impairment and ataxia. The thalamic diffuse midline gliomas, they present with raised ICT and sensory or motor symptoms. Coming to imaging, in the diffuse intrinsic pontine gliomas, the pons appears enlarged with the basilar artery displaced anteriorly against the clivus and appears potentially engulfed. The floor of the fourth ventricle is flattened, giving rise to the flat floor of fourth ventricle sign, and obstructive hydrocephalus may be present. Occasionally, these tumors are exophytic. That is, either they grow outwards into the basal cisterna or centrally into the fourth ventricle. Now, pre-treatment, these tumors appear homogeneous. However, in minority of patients, areas of necrosis may be evident. The thalamic diffuse midline gliomas may be unilateral or bilateral, and the bilateral DMGs frequently exhibit EGFR mutant subtypes. Coming to imaging findings, these are typically on CT scan, these are typically hypodense. On MRI, they show T1 sequences show decreased intensity and T2 show heterogeneity. Now, extensive spread is relatively found. They may go craniocaudally or may involve the cerebral hemispheres or the spinal cord, and leptomeningeal spread may also be seen. We have already seen the microscopy. So these tumors typically have astrocytic morphology, but some in occasional cases may have oligodendroglial-like pattern. The cells may vary. They may be small and monomorphic, and they may be large or pleomorphic. Some tumors, they exhibit grade 2 histology, and there may be absolutely no mitosis or necrosis or microvascular proliferation. But if a tumor is a midline and in a child or young adult, it must be subjected to the histone mutation study. The differential diagnosis is astrocytoma, CNS WHO grade 2, 3 and 4, which is IDH mutant, glioblastoma IDH wild type, and the posterior fossa ependymoma PFA. Nucleus. Coming to prognosis, prognosis remains poor with a 2-year survival of less than 10 years. Surgical options are limited due to tumor location. The diffuse midline gliomas harboring H3.1 or 3.2 mutations, or those showing EZHIP overexpression, have slightly more survival, that is 16 months, than those patients who have that is histone 3.3 mutations, and these patients have 11 months survival. It has been observed that P53 mutations, the patients showing P53 mutations may show radioresistance. The biothalamic gliomas with EGFR mutations have a survival of 10 to 14 months. Thank you very much.